All right, today we're going to jump into a super high-yield clinical update on managing hospitalized community-acquired pneumonia, CAP. We're going to walk through the essential evidence-based protocols you really need to have down right from the moment the patient hits the ER to the day they're good to go home. So let's dive in. Okay, picture this. Your next CAP admission just rolled in. The pressure's on, the clock's ticking. What's your game plan? What does the latest evidence say you should do right now? We are going to build that protocol together, step step.
So first things first, a really quick but super important clarification. We're talking about CAP, pneumonia picked up out in the community. And you'll notice the old term healthcare-associated pneumonia, or HCAP, is officially retired. Why? Well, it turns out that label was just way too broad. It was making us overtreat a lot of patients with big gun antibiotics they didn't need. The modern approach? Forget HCAP. Instead, you assess every single patient for their own individual risk factors for resistant bugs. We'll get to exactly how in just a minute.
So, that brings us to the very first fork in the road: arrival and assessment. And really, the most critical question right off the bat is, where does this patient belong? Can they go home? Do they need the medical ward? Or are they sick enough for the ICU?
To help make that call, we've got a couple of tools. The big one, the one we really prefer, is the Pneumonia Severity Index, or PSI. It's been properly validated and shown to be safe and effective for making this exact decision. Now, you also have CURB 65. It's definitely simpler, and it's not bad for predicting prognosis, but, and this is key, it's not validated for deciding that initial site of care. So bottom line, lean on the PSI. But let's be real, these are guides, right? Your clinical judgment is still king. All right, so you've figured out where the patient's going, ward or ICU. Now, before you even think about writing that first antibiotic order, we've got to identify the enemy. Who are the likely culprits here? What are we up against?
You know, the bugs we're fighting on the medical ward are a totally different beast than what we see in the ICU. On the ward, you've got your usual suspects: strep pneumo, a bunch of respiratory viruses, maybe some atypicals like mycoplasma or Legionella. But once you get to the ICU, while strep pneumo is still the champ, the whole game changes. You see a lot more Legionella, a lot more gram-negatives, and of course the big one we all worry about, Staph aureus. This difference is exactly why our empiric therapy has to change based on how sick the patient is. And this is really the million-dollar question that's going to shape your whole empiric strategy. Does this particular patient in front of you need coverage for MRSA or for Pseudomonas?
Look, you don't want to guess on this. You have to actively screen for risk factors. So for MRSA, what are we looking for? Well, a known history of it is a huge red flag. Same with recent IV antibiotics or a recent hospitalization. Or if you see something nasty on the imaging, like necrotizing changes or a cavity. For Pseudomonas, it's similar. Prior history or recent hospitalization are big ones, but you also have to be on high alert for patients with underlying structural lung disease, think bronchiectasis, or someone with really severe COPD who's on and off steroids and antibiotics all the time. These are the things that should make you stop and think about broader coverage.
Okay, let's get to the good stuff. The actual empiric therapy playbook. What are we starting them on? What do the guidelines say are our first-line regimens? Okay, so for your bread and butter CAP admission on the medical ward, no major red flags for resistance, the go-to is combination therapy. Specifically, a beta-lactam plus a macrolide. The classic combo is ceftriaxone 1 to 2 grams IV daily plus azithromycin 500 milligrams, which you can give IV or PO. Now, if you have an alternative, maybe a beta-lactam allergy, you can go with monotherapy using a respiratory fluoroquinolone like levofloxacin at 750 milligrams daily. Now let's level up to the ICU. For severe CAP, the strategy is similar, but we're definitely dialing it up a notch. You need a solid antipneumococcal beta-lactam, like ceftriaxone again, or ampicillin sulbactam, 3 grams IV every 6 hours. And to that, you're going to add either a macrolide like azithromycin or a fluoroquinolone. And here's a key point. A lot of the observational data suggests that using a macrolide here might actually improve outcomes, maybe because of its anti-inflammatory effects. So it's generally preferred. All right, but what happens if that risk factor screen we talked about a minute ago lit up like a Christmas tree? What do you do if you really do suspect MRSA or Pseudomonas? How does that change the playbook?
It's pretty straightforward. If MRSA is on your radar, you're going to add either vancomycin, and you'll want to target troughs of 15 to 20, or linezolid, 600 milligrams IV every 12 hours, to your base regimen. Now for Pseudomonas, it's a bit different. You're actually going to swap out your beta-lactam for one with anti-pseudomonal activity, like piperacillin tazobactam, 4.5 grams IV every 6 hours, and you need to make sure your second drug is an anti-pseudomonal fluoroquinolone, like levofloxacin.
Okay, let's switch gears and talk about something that can be a little controversial: adjunctive steroids. This is a hot topic. The question isn't really if we should ever use them, it's who actually gets a real benefit from them. Let me be crystal clear on this. Steroids are only for your sickest patients. We're talking about the ones with severe respiratory failure, who are on a ventilator, invasive or non-invasive, or have significant hypoxemia, like a P to F ratio less than 300 on at least 50% FiO2. The studies show the mortality benefit is real, but it's greatest when you start them early. This is absolutely not for your average CAP patient on the floor.
And if you are going to use them, you have to use the right recipe. The evidence is for hydrocortisone, 200 milligrams per day. Run as a continuous infusion for about 4 to 7 days, and then you follow that with a taper. You've got to be precise to get the benefit.
But, and this is a big but, there are some absolute deal breakers, times when steroids are a definite no-go. If you have active flu, or you even suspect TB or a fungal pneumonia, steroids are off the table. They can make things much, much worse.
All right, fast forward a bit. Your patient is starting to turn the corner. They're responding to your treatment. Now we're in the final phase, the road to recovery. And this is all about being smart with de-escalation and setting them up for a safe discharge.
So when can you finally pull that IV and switch to pills? It's actually a really simple 4-point checklist. 1. Are they hemodynamically stable? 2. Are they clearly improving clinically? 3. Can they actually take things by mouth? And 4. Is their gut working? If you can check all 4 of those boxes, they are ready to switch to oral antibiotics.
And here's a huge clinical pearl, one that'll save you and your patient a lot of headaches. The chest X-ray always lags behind the patient. It gets better way more slowly. So please do not keep someone in the hospital or prolong their antibiotics just waiting for that X-ray to look pretty. Treat the patient, not the film.
So the big question, what's the magic number for duration of therapy? For most of your uncomplicated CAP patients, the ones who are stable, fever-free, and doing well, the answer is 5. Just 5 days. Not 7, not 10. The evidence is really strong for this now.
Now, obviously, there are exceptions to the rule. If you're dealing with a complication like an empyema or a lung abscess, you'll need longer. Same goes if you've got a documented Pseudomonas infection or an MRSA pneumonia with bacteremia. But for your standard issue CAP, 5 days is the new standard of care.
Okay, so if you remember nothing else from this, remember these 3 things. Number 1, risk stratify every single patient with the PSI to decide where they need to be treated. Number 2, tailor your empiric antibiotics. Base it on how sick they are and whether they have those specific risk factors for MRSA or Pseudomonas. And number 3, embrace antibiotic stewardship. Aim for the shortest effective course, which for most of your patients is going to be just 5 days.
And that's really where we'll leave it. We've gone over the playbook for today, but the bugs are always getting smarter, right? Resistance patterns are changing all the time. So the final question for you to think about is, how are you going to keep adapting your strategy, not just today, but tomorrow and next year? Thanks for tuning in.